I want to thank the NADF for inviting me to talk to you today about adrenal insufficiency in children and adolescents. As the primary healthcare providers in the school setting, it's very important for you to recognize the signs and symptoms of adrenal crisis and to be familiar with its treatment. So I'd like to start with a clinical case of a 15-year-old boy who presents to the school nurse complaining about dizziness upon standing. He has morning headaches, which frequently make him late for school. He has a poor appetite and has been losing weight without trying to do so. His grades have suffered over the past few months. So which of the following conditions might you suspect? A, anorexia, B, infectious mono, C, depression, D, adrenal insufficiency, or E, all of the above? Well, the correct answer is all of the above. And I want to send you away with this take-home point that the signs and symptoms of adrenal insufficiency, also termed AI in this presentation, mimic several other chronic conditions. These include fatigue, lethargy, depression, confusion, headaches, dizziness, anorexia and vomiting, dehydration, low blood pressure, fainting or shock, and a tan skin pigmentation. If one is to do blood tests, the common findings are a low blood glucose, low sodium, and high potassium levels. Another take-home point is that the family history can help identify the cause of adrenal insufficiency. So questions that ought to be asked in this setting are, is there a relative with adrenal insufficiency, and at what age was it diagnosed? Do autoimmune diseases run in the family, for instance, type 1 diabetes, Graves' disease, and hypothyroidism? And were there any unexplained early infant or childhood deaths in the family? Any affirmative answers to these questions may suggest a genetically transmitted condition. Also, a careful medical history can identify the cause of adrenal insufficiency. Ask the family, at what age did the child first experience symptoms or signs of a medical problem? If this occurred in early infancy, then a congenital or genetic disorder is likely. Does the child have a past history of any other medical problems? A recent serious infection could have triggered adrenal insufficiency. And has he or she been hospitalized for any medical conditions? Is there a known diagnosis? Has the child had surgery, and what type of surgery? Removal of the adrenal gland or the pituitary could trigger adrenal insufficiency. And this may not be done for a problem actually primarily related to adrenal insufficiency, but for instance, a tumor that needs surgery could be the cause for this event to be precipitated. Has the children taken any medications or been exposed to toxins? So most commonly, long steroid administration may suppress the innate adrenal function, and the risk of adrenal insufficiency is great if the glucocorticoid medication or steroids are suddenly stopped. Some medications or toxins may interfere with adrenal function, and this includes several of the antifungal medications. Has the family physician observed any unusual changes in the child's behavior or daily function? Deteriorating cognitive or motor function could signal a neurodegenerative disorder, such as adrenoleukodystrophy, which is now screened for in several states in the newborn screen. So we divide the causes of primary adrenal insufficiency into three general categories. There are congenital causes, acquired causes, and syndromic causes. Among the congenital causes are enzyme deficiencies, such as seen in congenital adrenal hyperplasia. There are storage diseases, such as Wolman disease, developmental defects, such as adrenal hypoplasia congenita, in which the adrenal glands don't develop properly in utero. And there are receptor defects that include ACTH resistance or glucocorticoid resistance. Among the acquired causes of adrenal insufficiency are autoimmune diseases, most commonly Addison's disease, infectious meningococcus, AIDS, tuberculosis, which is now experiencing a resurgence, and COVID-19. Trauma can injure the adrenal glands so that they don't produce the normal products. Iatrogenic drugs that we mentioned earlier, such as antifungal ketoconazole, and toxins, including heavy metals, most prominently lead. Syndromic causes include adrenoleukodystrophy, which may not present in early infancy but is gradually progressive, Kearns-Sayre syndrome, a mitochondrial disorder, receptor resistance, such as Old-Grove syndrome, or image disorder. We don't have time to go into detail on any of these causes today, but I can give you references to explore this further if you're interested. The causes of secondary adrenal insufficiency include pituitary trauma or surgery, brain tumors which impinge on the pituitary gland. Most commonly in childhood, these include craniopharyngiomas, a cystic tumor around the pituitary gland, and suprasellar germ cell tumors. There are infiltrative pituitary diseases which destroy the pituitary, such as sarcoid and histiocytosis, and congenital pituitary abnormalities in which a person has progressive loss of corticotropin function. And finally, most commonly, chronic glucocorticoid therapy, which suppresses the innate pituitary and adrenal function. So careful physical exam is crucial to diagnosing AI. And in primary adrenal insufficiency, there's an increased production of ACTH, or adrenal corticotropic hormone, which in addition is accompanied by excess melatonin secretion. And this may cause a tan skin appearance in non-sun exposed areas. Alternatively, one can have vitiligo, which are white spots due to loss of melanin skin pigment, and that's seen in autoimmune adrenal insufficiency. Cardiovascular insufficiency, noticed by the presence of low blood pressure, fainting, or shock, and the loss of axillary pubic hair due to inadequate adrenal androgen production. Deteriorating vital signs are an important clue to impending adrenal crisis. If the patient has low blood pressure of, say, 90/60, a rapid pulse at 124, and as he himself states, when he rises from a lying position, he nearly faints. His blood pressure in your office is 80/55, and his pulse is up to 144. So what should you do next? Well, acute adrenal insufficiency demands prompt treatment, and the acute treatment that we usually prescribe is stress dosing of a glucocorticoid known as hydrocortisone, or the trade name Solu-Cortef here in the US, by either intramuscular or intravenous injection, and this should be followed every 6 hours by further administration of hydrocortisone until the crisis has resolved, and usually this is carried out for 24 to 48 hours. This usually includes a 50 milligram dose at each dosing for elementary school students and 100 milligrams for high school students. The healthcare professional who sees the patient in the school setting should call 911, and the EMTs who arrive should be prepared to insert an intravenous line with liberal volumes of electrolyte-containing fluids, usually normal saline or lactated ringers, and then the individual will require continuous medical observation for 12 to 24 hours in most cases. Now, the chronic treatment of adrenal insufficiency involves more modest dosing of glucocorticoids, usually given as oral hydrocortisone divided in 2 to 3 daily doses, and these are adjusted to the patient's sense of well-being and function and to the vital signs. Mild illness may require a doubling or tripling of the daily maintenance dose and then given every 6 hours rather than every 8 hours. Midday dosing may help reduce fatigue, and daily mineralocorticoid and sodium supplements are given as needed. Salt craving and intense physical activity that induce increased sweating may be indication for these salt-retaining treatments as well. Now, there are several resources available to you to learn how to give Solucortef injections to children. If you haven't already done this, I recommend that you view at least one of these presentations that are available online for this purpose. Now, who should be treated with stress doses of glucocorticoids? So any child or adult with congenital or acquired forms of primary or secondary adrenal insufficiency, especially at times of gastrointestinal illness, fever greater than 101 Fahrenheit, or at the time of surgery and immediately beforehand and afterward. Any patient who's treated with pharmacologic doses of glucocorticoids for more than 2 weeks within the past year and is experiencing one of these stressful situations noted above should also receive stress glucocorticoid dosing. Endocrinologists should educate patients and their families of the need to get stress dosing and when to give the injection of hydrocortisone and call 911. Parents should be given written information and share this with the health department in their schools. Patients must carry emergency instructions and wear a medical alert tag that can be prominently displayed and shown to emergency personnel. Students with adrenal insufficiency should always be accompanied by a knowledgeable adult on school trips. This can be life-saving. So, best practices for treating adrenal crisis in emergency. The National Adrenal Diseases Foundation has emergency kit recommendations. Make sure you include your emergency contact, your endocrinologist information, and this crisis flyer, which again can be printed out at this website. You should carry with you a Solucortef Acto vial. Make sure that if traveling away from home, this is in your carry-on luggage. Syringe, needles, and alcohol swabs are also included in the kit. So in summary, the treatment of adrenal insufficiency, the mainstay is hydrocortisone, which is the glucocorticoid drug of choice for children and adults. The maintenance dose approximates a slightly higher dose than is produced by the adrenal gland, and lower maintenance doses are needed in Addison disease, primary adrenal insufficiency, compared with, for instance, congenital adrenal hyperplasia. Higher doses in stress, usually 3 or so times the maintenance dose, given every 6 hours rather than 2 to 3 times a day. And parenteral dosing for crisis includes Solucortef, and a general rule of thumb is 100 milligrams IM intramuscular for adolescents, 50 milligrams for middle school children, and 25 milligrams for toddlers and preschool children, either IM or IV, and this must be given immediately as soon as the condition is diagnosed or suspected, and then followed by about 100 milligrams per meter square per day in divided doses every 6 hours until stable. And obviously, this would need to be given parenterally rather than the oral route if the child is vomiting. Fludrocortisone is helpful as a maintenance treatment, and this is given in a dose of 0.05 to 0.2 milligrams daily, and usually once or twice a day. This is useful in all patients with classic CAH and any AI patient with salt craving or a high plasma renin activity. Sodium chloride may be necessary in a dose of approximately 1 gram daily, and this is useful in classic CAH and in any patient, as I said, with salt craving. So that's the end of my presentation, and I'd be happy to entertain any questions. Thank you for your attention.